Good morning, everyone. I'm sorry if you were in my tutoring session last night. For some reason, Zoom kind of froze up on me, and the only way to get out of that was to force shut down my computer. So I'm recording this off of Zoom, and hopefully that'll actually be better for you because the recording should be quicker. Okay, starting with the lecture on the pharmacology of histamine and bradykinin. The first thing of importance that she mentioned was scombroid poisoning. And scombroid poisoning occurs when the bacterial histidine decarboxylase converts histidine from the proteins in the fish into histamine. So you can see that reaction over here going from histidine to histamine via histidine decarboxylase. So I would focus on knowing this step in the reaction right here. And some of the signs and symptoms associated with scombroid poisoning would be oral burning, vomiting, diarrhea, urticaria, flushing, and fever. And I wouldn't worry too much about knowing exact temperatures over here. Just know that, there's a range of temperatures that are considered sort of a danger zone that bacteria grow very quickly in. So if somebody is on, say, like a deep sea fishing trip, it's important to store the fish properly to avoid something like this from happening. And surprisingly, this lecture was taught by a different professor last year, and we never learned this, and we actually never learned it in second year either. But I was surprised to, see here it is right in first aid. So to me, it seemed a little bit random, but obviously something that first aid finds important. So scombroid poisoning comes from spoiled dark meat fish, such as tuna, mahi mahi, and mackerel. And again, it occurs by bacterial histidine decarboxylase, which converts histidine to histamine. And it's frequently misdiagnosed as a fish allergy. So, some of your signs and symptoms that she mentioned is the fact that this poisoning can mimic an anaphylactic like reaction. So you get that acute burning sensation of the mouth, flushing of the face, erythema, urticaria, itching. And then I suppose if this goes untreated, it may progress to bronchospasm, angioedema, and then hypotension, which could, of course, be very dangerous. So you're going to treat it with antihistamines, which makes sense since this is a histamine-mediated reaction. And then also albuterol for the possible bronchospasm and epinephrine for the anaphylactic-like reaction. Okay, so your antihistamines consist of both H1 blockers and H2 blockers. I would say your H1 blockers are definitely, you're more likely to be asked about them, and that's due to this very important point right here, the fact that they cross the blood-brain barrier and have CNS effects. So examples of H1 blockers would be diphenhydramine, hydroxyzine, and meclizine. And important side effects include sedation, and this is due to the fact that it can cross the blood brain barrier and have CNS effects. So, sedation, paradoxical CNS stimulation. So, rather than acting as a sedative, you can actually see somebody go in the opposite direction when they take this. You may see impaired cognition, weight gain, and then the thing I would pay the most attention to here would be the anticholinergic effects. So, specifically, antimuscarinic effects like dry mouth, dry eyes, and then mydriasis, which she stressed, tachycardia, anhidrosis, urinary hesitancy, and constipation. So, you talked about this last block. So, anytime a drug causes mydriasis, it's going to be contraindicated in patients with narrow angle glaucoma. So I would expect to see something on the exam involving H1 blockers and their anticholinergic effects. And then also, H1 blockers can have alpha 1 blocking effects. So remember, alpha 1 is your vasoconstrictor. So if you're blocking alpha 1, you could see orthostatic hypotension. So if someone stands up really quickly and their blood pressure bottoms out, you can see how this would increase the risk of falls. Next are your H2 blockers, and these include drugs like loratadine, cetirizine, and fexofenadine. And very important to know is the fact that these do not cross the blood-brain barrier. And this is because they're ionized at physiologic pH. So with H2 blockers, you're going to see less sedating effects than H1 blockers. And then also, several of these drugs were taken off the market, and that's due to the fact that they can prolong the QTC due to their ability to block the inward rectifying potassium channel. And this leads to risk of torsades. So here it is out of first aid. I would pay attention to the fact that H1 blockers, they act as sedatives. They have anti-muscarinic effects, so remember mydriasis especially, and then also anti-alpha adrenergic effects. And then in second generation H2 blockers, they're less sedating than H1, and this is due to the decreased entry into the CNS. So if you remember that H1 blockers, they can get into the CNS, I think that helps you remember some of these adverse effects. Okay. The next thing here is drug-induced angioedema, and this is a very high-yield topic that's going to come back again and again in second year when you talk about ACE inhibitors. So your drugs that can cause angioedema include your ACE inhibitors, so the pills like lisinopril or captopril, and your ACE inhibitors, just to review, are going to prevent the conversion of angiotensin 1 to angiotensin 2, and that's by blocking ACE. Also, your neprilysin inhibitors and your DPP4 inhibitors, which you'll talk about in the next block that covers endocrine. I would definitely focus on the ACE inhibitors, though. I think that's the one that you're most likely to be asked about for this exam. So if you give a patient an ACE inhibitor, not only is it blocking the conversion of angiotensin 1 to angiotensin 2, but it's also blocking the breakdown of bradykinin. So remember, bradykinin is a very potent vasodilator, and that's what leads to this drug-induced angioedema. So if you have a patient who presents with drug-induced angioedema, especially through the use of H inhibitors. H inhibitors are first line for the treatment of hypertension. And rather than taking the patient off of a drug that's doing such a good job, we can try to treat the angioedema through drugs that target reductions in bradykinin activity. So the drug to know for this exam is icatibant. So icatibant is a bradykinin receptor antagonist, and it's approved for use in hereditary angioedema. And then it's also used for, it's used off-label for drug-induced angioedema. So for example, in angioedema caused through the use of ACE inhibitors. All right, so a few practice questions, and just skip ahead to the answer here. So the answer here is histamine, and this question stem is describing scombroid poisoning. So what would tip you off here is the fact that this patient presented with nausea, vomiting, and diarrhea. He also had a fever, and then you noticed raised smooth wheals and plaques around his neck. So that's describing the urticaria. And then another hint would be the fact that the history fits here, noting that he recently became ill after returning from a fishing trip in Florida. So this stem, should lead you towards scombroid poisoning. So that's where the histidine decarboxylase, the bacterial histidine decarboxylase, converts histidine to histamine, and you see the anaphylactoid-like reaction. Okay, so with this next question, the correct answer is diphenhydramine. So this is your H1 blocker. So this question describes a young female who presented to the ER agitated and confused. She had dilated pupils, so mydriasis, a rapid heart rate, dry axilla, and dry mucous membranes. So that's describing your anticholinergic effects that you would see with your H1 blockers because they're penetrating the CNS. And that fits with the history here, the mother talking about the girl complaining of allergies. So diphenhydramine is a medication that, she may have taken. And you can roll out the other three because these other three here are H2 blockers. So you're going to see less penetration to the CNS. Okay, so this question is describing drug-induced angioedema. So, you have a 50-year-old female, and you recently started her on lisinopril to treat her hypertension. And she says she thinks that she's allergic to the medication, and you notice that when you examine her that her tongue is swollen. So you explain to her that this is one of the side effects of lisinopril, referring to the drug-induced angioedema. So in order to treat this, you're going to prescribe her a bradykinin receptor antagonist because the bradykinin, the breakdown of bradykinin is being blocked by the ACE inhibitor, and that's what's causing the angioedema. So what is the name of the drug you prescribe to treat drug-induced angioedema? And that's going to be icatibant. And while I'm here, I'm going to go ahead and fix this little typo because that's going to bother me. Okay. So the next lecture is on costanoids and NSAIDs. So just a little clip here out of first aid to kind of go over the pathway. So phospholipase A2 is going to cleave membrane phospholipids and produce arachidonic acid. Arachidonic acid is either going to head down the lipoxygenase pathway to produce leukotrienes or the cyclooxygenase pathway to produce prostacyclins, prostaglandins, or thromboxane. A couple important points that she made is the fact that your leukotrienes are going to increase bronchial tone, so potentially leading to bronchospasm in the patient. And then PGI2 decreases platelet aggregation. So if you're like me and you have trouble remembering what these things do, so first aid suggests remembering that PGI2 is a platelet gathering inhibitor, so maybe that'll help. And then thromboxane A2 increases platelet aggregation. So I remember this with A for aggregation. And then your prostaglandins, PGE1 and PGE2. So PGE1 is going to decrease vascular tone, and this one you'll often see questions about, referring to the fact that it maintains the patency of the ductus arteriosus. And then one of her ding-dings was definitely this PGF2 alpha, which is going to increase uterine tone. So if you have a female patient who is experiencing postpartum hemorrhage, you can give her a drug called Carboprost, and that's going to increase uterine contraction by increasing uterine tone and control her postpartum bleeding. So again, this PGF2 alpha, it increases smooth muscle contraction. So it leads to very powerful uterine contractions. And carboprost can be used to control postpartum bleeding. And one of the adverse effects that she really stressed is the fact that if you use carboprost, your patient can see GI cramping and diarrhea. And then again, the fact that prostaglandin analogs like carboprost can cause diarrhea. Okay, so something very important to kind of get your head around and keep straight is where are prostaglandins acting in the kidney and where is angiotensin 2 acting. So prostaglandins dilate the afferent arteriole. Um, so first aid suggests remembering PDA. And I really like that because when I read that PDA, I was like, oh, patent ductus arteriosus, which, doesn't have anything to do with the kidney. But if you remember that prostaglandins maintain the patency of the ductus arteriosus, then that little mnemonic kind of serves two functions here. And then also the fact that angiotensin 2 constricts the efferent arteriole. So if you give a patient an ACE inhibitor, you're reducing the synthesis of angiotensin 2. So instead of seeing constriction of the efferent arteriole, by removing the angiotensin 2, you'll see dilation. All right, aspirin and asthma. So, aspirin is an NSAID and it's going to inhibit the cyclooxygenase pathway. So, by inhibiting the cyclooxygenase pathway, you're decreasing the production of prostaglandins and you're going to have more arachidonic acid to go down the lipoxygenase pathway. And this is through what she described as the law of mass action. And as a result, you're going to see an increase in the synthesis of leukotrienes. So if you increase the synthesis of leukotrienes, a patient with a history of asthma, may experience bronchospasm leading to an asthmatic flare. And also important to know is the fact that aspirin irreversibly inhibits COX and platelets. So you're going to decrease the formation of thromboxane A2 for the life of the platelet, and this has an anti-aggregatory effect. And then your cardinal signs of salicylate toxicity are going to be tinnitus and a wide anion gap acidosis. So if you see a question stem describing kind of like an overdose situation and it mentions that the patient has ringing in their ears, that's definitely a tip-off that you could be dealing with aspirin overdose. And then the last point here is the fact that your COX-2 inhibitors are going to increase the risk of clot formation because they selectively block the formation of PGI2. And PGI2 decreases platelet aggregation. So if you're blocking the formation of PGI2, you can see how that would lead to a risk of clot formation. And then I pulled this out of her lecture. So COX-1 inhibition is going to decrease the amount of thromboxane A2, and this has an anti-aggregatory effect. However, it increases your risk for GI bleed. So COX-2 inhibition decreases the amount of PGI2, and this is pro-aggregatory. However, you have a less risk of a GI bleed. So your aspirin is definitely going to lead towards COX-1 inhibition. Okay, and I pulled this back out of the first tutoring session uh, of this block just to go over this again because this is very, very important, very high yield. So in a hypotensive patient, you're going to see a decrease in renal blood flow and subsequent decrease in GFR. You'll also see an increase in prostaglandins as a result and an increase in renin and angiotensin 2, and that's mediated by PGI2. So you'll under this circumstance, you would see vasodilation of the afferent arteriole through prostaglandins and vasoconstriction of the efferent arteriole mediated by angiotensin 2 in order to maintain the GFR. Okay, so going down to the pictures here, if you give a patient an ACE inhibitor, so normally angiotensin 2 would vasoconstrict the efferent arteriole. However, if you're giving someone an ACE inhibitor, you're decreasing the production of angiotensin 2. So instead of vasoconstriction, you'll see vasodilation. And this is going to further decrease the GFR. If a patient is on an ACE inhibitor and then you add an NSAID, so normally NSAIDs, without an NSAID, prostaglandins are going to vasodilate the afferent arteriole, but if you block prostaglandin formation, you're going to see vasoconstriction of the afferent arteriole, which is going to further decrease the GFR. So she mentioned in her lecture that renal toxicity is additive with other renal toxins. So low-dose aspirin is not likely to be a problem. So it's not to say that a patient on an ACE inhibitor just can't take aspirin or can't take an NSAID, but you're definitely going to monitor the dosing, and you're going to monitor renal function. And then one important interaction or contraindication that Dr. Quadri talked about was the use of ACE inhibitors in renal artery stenosis. So this slide is out of his lecture. Sorry, I just gotta populate the animations. So if a patient has an obstruction in the afferent arteriole, that's going to decrease renal blood flow, and that will lead to a decrease in GFR. And then sodium filtration is going to decrease, and less sodium will be delivered to the juxtaglomerular apparatus, and this leads to increased secretion of renin and increased conversion of angiotensinogen to angiotensin 1 and then angiotensin 1 to angiotensin 2. So normally angiotensin 2 acts at the efferent arteriole as a vasoconstrictor, and it does this to maintain the GFR. However, if you give a patient with renal artery stenosis an ACE inhibitor, you're going to block the production of angiotensin 2, and rather than seeing vasoconstriction here at the efferent arteriole, you're going to see vasodilation, which rather than maintaining the GFR is going to further decrease it. So in somebody who already has, renal damage or a condition like renal artery stenosis, ACE inhibitors are definitely something that you may avoid due to this, further decrease in renal function. Excuse me. Okay, so last important thing in this lecture um, is going to be involving acetaminophen toxicity. So, in a patient who is an alcoholic, alcohol is going to induce CYP452E1, and that's going to drive acetaminophen metabolism uh, towards this toxic intermediate that's NAPQI. And then, if you have an alcoholic patient, oftentimes they're doing a lot of drinking and not a lot of eating. So, it's very possible that they may be malnourished, which leads to a depletion of glutathione. So, with glutathione, that's going to drive a NAPQI in this direction, leading to hepatic necrosis. So, your antidote for acetaminophen toxicity is going to be an acetylcysteine, which replenishes glutathione in order to appropriately detoxify NAPQI, leading to renal excretion rather than hepatic necrosis. So, like I've said before, anytime you have like an overdose or a toxic situation in farm, it's definitely important to know the antidote or how you're going to approach treating that situation. Okay, so in this question, the correct answer here is diarrhea. So remember, if you're giving someone a prostaglandin analog like carboprost, you're going to control postpartum hemorrhage through PGF2 alpha, but one of the important side effects are going to be the increase in GI motility and the GI cramping and diarrhea that would follow administration of something like carboprost. Okay, so um, this question is I took this straight out of Dr. Babos's lecture and tried to make it into a practice question. So here she's talking about aspirin and your asthmatic flare. So you have a patient with chest pain from myocardial infarction. He was given 4 chewable 81 milligram aspirin. Shortly after taking the aspirin, he developed a severe asthmatic attack. And this is due to the increased synthesis of leukotrienes. So, if you remember that arachidonic acid pathway, if you're blocking this cyclooxygenase pathway, instead of producing prostaglandins, you're going to go down the lipoxygenase pathway instead and produce leukotrienes. So instead of increased synthesis of prostaglandin, it would be decreased, and you would deactivate the cyclooxygenase pathway because you're blocking it by giving an NSAID. And then instead of inhibition, you would see activation, further activation of the lipoxygenase pathway through the law of mass action. Okay, and if you were in my session last night, I sort of fudged on this question, but I have fixed it now, and this is a good question. So, which statement below is accurate regarding aspirin overdose? So, N-acetylcysteine is not the correct answer here, and that's because you're going to give N-acetylcysteine in an acetaminophen overdose, not an aspirin overdose. So, option A here, the metabolism of aspirin is first order. That's not correct. So the metabolism of aspirin is 0 order. And if you remember that mnemonic out of first aid, it was PEA. So things following 0 order metabolism are going to be ethanol, aspirin, and then I believe it's phenytoin. And then your elimination rate is directly proportional to plasma concentration. This is not correct because your elimination rate in zero order kinetics is not related to the plasma concentration. So our last option here would be increasing urinary pH would be beneficial, and that's because if you increase urinary pH, you create an alkalinized environment. And aspirin, being an acidic drug, which you should know, is going to be trapped in an alkaline environment because in that environment it's going to be ionized due to the fact that it can easily give up protons. So I brought this all back just kind of as a review and to encourage you not to get confused like I did, and don't mix up aspirin overdose with acetaminophen overdose. So N-acetylcysteine is for acetaminophen overdose, not aspirin. And then, knowing the kinetics is definitely going to be something, that could show up on your cumulative for sure. And then that is, high yield for boards. So straight out of first aid here is zero versus first order elimination. So aspirin is zero order. And it's eliminated, constant. There's a constant amount of drug eliminated per unit time, and the rate of elimination is constant regardless of the plasma concentration. And then your PEA, remember that phenytoin, ethanol, and aspirin. Okay. Here's just a review from the first exam. So your ionized form of the drug is going to be trapped. And, remember that a drug must be ionized in order to trap it in the urine. And then acidic drugs like aspirin, they're going to be ionized in an alkaline environment because they can readily donate their proton. So right here is where we would be at. All right, so hematopoiesis and coagulation. So there was a lot of stuff in this lecture, and for me, I think this is like one of the hardest physio topics is, the intrinsic versus extrinsic pathway and the coagulation cascade. I wouldn't stress yourself out about that too much right now, especially since neuro, it takes a lot of time. So I try to, really focus in on her Weebots here. So the first thing that she really stressed was the use of erythropoietin. So erythropoietin is important in end-stage renal disease because your kidneys don't make enough in order to stimulate red blood cell production. And then also in AIDS and HIV patients or in patients who can't take infusion, you can stimulate red blood cell production with erythropoietin prior to surgery. Okay, erythroid colony stimulating factors are going to be your epoietin alpha and your darbepoietin alpha. And they work by stimulating the erythropoietin receptor to increase erythropoiesis. And two of the adverse effects that she stressed are hypertension and your increased risk of thrombotic events. So, for example, stroke and DVT. And this is due to the fact that hematocrit is directly related to viscosity, and viscosity is directly related to resistance. So, if you see polycythemia, you're going to increase resistance and decrease the flow at any given pressure, leading to that increased risk of thrombi and increased blood pressure. So your phase is in coagulation homeostasis. A couple important points here is that protein C and S are endogenous anticoagulants. And then D-dimer, something that you'll talk a lot about next year, it's used as an initial screen in the detection of DVT. And D-dimer is a breakdown product of fibrinolysis. And then your test of importance. So your bleeding time is a measure of your platelet function. The partial thromboplastin time measures heparin activity. Your PT is a measure of warfarin activity. And then your anti-TNA assays are a measure of low molecular weight heparin. And then again, she made a big point about your vitamin K dependent anticoagulants being protein C and protein S, and a deficiency in these are going to increase your venous thrombotic risk. Okay, so warfarin is going to inhibit your vitamin K oxide reductase. So when vitamin K um, stays in the oxidized form, it cannot donate a carboxyl group to activate factors 2, 7, 9, 10, protein CNS, and osteocalcin. Okay, and then her last definite WEBA in this lecture is the fact that in non-heparinized patients with an underlying protein CNS deficiency, they're going to have a risk of warfarin-induced skin necrosis. So if this is very confusing to me as well. So if you caught her email, I guess it was yesterday, she mentioned that protein CNS, they're vitamin K dependent anticoagulants, and they have super short half-lives. So when you add vitamin K, a vitamin K antagonist, like for example warfarin, your shortest half-life agents like vitamin C and S, they're going to be impacted first. So your anticoagulant effects are gone before your procoagulant activities are diminished. So if somebody already has a protein CNS deficiency, if you add warfarin without inhibiting your intrinsic pathway with heparin, this is going to lead to coagulation before your anticoagulant effects are seen. So that's where you're getting the warfarin-induced skin necrosis. Okay, so this question is describing a patient with end-stage renal disease receiving epoetin alpha to increase erythropoietin production. So which of the following side effects is he at risk for? So that's going to be stroke due to your increased risk of thrombotic events, and then instead of hypertension, you can see hypertension. A deficiency in which of the following vitamins will increase risk of venous thrombosis? So that's a vitamin K deficiency. And then warfarin should be bridged with heparin therapy to ensure the patient doesn't have a deficiency of which of the following, and that's going to be protein CNS, because if you're not giving patient on warfarin, if you're not giving them initially heparin, then you can see an increased risk of skin necrosis. Okay, so immunosuppressants. Very important to know are your live vaccines. So, your live vaccines would include influenza, MMR, and varicella. Definitely the three most important ones to know. So, you should not give a live vaccine to a patient on an immunosuppressant, and this is due to the risk of infection. So, examples of immunosuppressant drugs, the one she had in red was adalimumab, so I would know that one for sure. Okay, so your glucocorticoids, just kind of a review here from endocrine. Your suprachiasmatic nucleus is going to trigger the hypothalamus to secrete CRH in the early morning hours. So they say that waking up is the most stressful part of the day. And then CRH is going to stimulate the anterior pituitary to secrete ACTH. And ACTH is going to stimulate the zona fasciculata of the adrenal cortex to produce cortisol. And cortisol, at high levels, has the potential to turn off the immune system and then also produce a negative feedback on both CRH and ACTH release. And this negative feedback, for example, in a situation of long-term use of exogenous steroids, it can cause adrenal atrophy because um, it's not being stimulated. Your effects of exogenous corticosteroids in the short term are going to include hyperglycemia, hypertension, hypokalemia, and decrease in white blood cell margination, and then immune suppression. And what's important here are the long-term effects of exogenous corticosteroids. So initially, or after 7 days, you can see kind of a Cushing-like syndrome. So you get fat redistribution leading to the moon phases, striae, thin skin, and osteoporosis. And then if the patient suddenly stops taking the corticosteroid or you discontinue the corticosteroid without tapering it, it's going to lead to what is known as steroid discontinuation syndrome. So initially that patient who has um, stopped the corticosteroid, whether through self-choice or following the physician orders, can experience kind of these non-specific symptoms like abdominal pain, nausea and vomiting, or fatigue. And then eventually this could precipitate an Addisonian-like crisis. So sudden discontinuation of the drug occurs because you didn't taper the patient, or if they're exposed to a physiological stressor. And then your Addisonian-like crisis is just going to mimic the symptoms of Addison's disease. So the two most worrisome would be the hypoglycemia and then the hypotension. Your cytotoxic agents include anti-metabolites. And one of the important side effects that she talked about was hyperuricemia. So your cytotoxics like azathioprine are going to cause cell death, and then the dead cells are going to spill their DNA into the bloodstream. So your purines are released and then metabolized to uric acid, leading to hyperuricemia, which has toxic effects. And then azathioprine, so it's metabolized by xanthine oxidase, and there's a fatal drug interaction that occurs when you give a patient on azathioprine allopurinol. And the reason you would do that, the reason that you would give a patient on azathioprine allopurinol is to prevent the hyperuricemia through the inhibition of xanthine oxidase. So while you're doing a good thing by inhibiting hyperuricemia, you could also have a fatal interaction over here because since azathioprine is broken down by xanthine oxidase, when you inhibit that, instead of getting harmless metabolites from the drug, you get a situation where the drug isn't broken down, and then you can see toxic effects from that. So if you give a patient allopurinol while on azathioprine to prevent the hyperuricemia, you must monitor the CBC, and that's because your patient can die due to aplastic anemia. Your next antimetabolite that she stressed was methotrexate. So, methotrexate is a dihydrofolate reductase inhibitor. And the ding ding here is the fact that your red blood cells in anemia caused by methotrexate, it's going to be a megaloblastic anemia. So in a megaloblastic anemia, you're going to see hypersegmented neutrophils and then macrovalocytes. And the antidote for this is going to be folinic acid. So the drug name is actually leucovorin. So if you hear someone talking about a leucovorin rescue, which I believe Dr. Weaver does in her last lectures, this is an antidote to methotrexate toxicity causing megaloblastic anemia, which is a deficiency in vitamin B12 or folate. So you're going to give folinic acid to treat that megaloblastic anemia. Your cell signal disruptors are cyclosporin and tacrolimus, and these are both calcineurin inhibitors. So the calcineurin inhibitors are going to inhibit dephosphorylation of your INFAT, and this leads to the inhibition of IL-2 autoinduction that's necessary for T cell proliferation. And as a result, you can see an increased risk of infection with cyclosporin or tacrolimus. All right, so the correct answer here is D-TAP. And this question is talking about a 19-year-old patient who is now pregnant, and she discovers that maybe she's unvaccinated. So she, being concerned for her child, she's open to getting all recommended vaccines. So what I'm trying to get across to this question here is that you should not give a patient who is pregnant, they should not receive any live vaccine, so varicella, influenza, or MMR. And that's because a pregnant patient, so being pregnant, is actually an immunosuppressed state. However, diphtheria, tetanus, or acellular pertussis would actually be fine and even recommended to give a pregnant female. What effect will allopurinol have on the activity of azathioprine? So enhance retention and potentiation of the activity of azathioprine. And that's because allopurinol, remember, is an xanthine oxidase inhibitor. So if you're inhibiting this enzyme, you're going to potentiate the activity of azathioprine. So this question is describing the megaloblastic anemia that you might see in a patient taking methotrexate. And the antidote in this case would be folinic acid or leucovorin, so your leucovorin rescue. Okay, last lecture here, talking about your vaccines. Hopefully, since you guys had Dr. Greg this year, who seemed pretty amazing, hopefully he talked to you guys about the use of RhoGAM. So, in a pregnant female, during her first pregnancy, the mother will be exposed to fetal blood and that often occurs during delivery, and you're going to get the formation of maternal anti-D IgG. So in subsequent pregnancies, your anti-D IgG can cross the placenta and lead to hemolytic disease in the newborn. And this is referring to an Rh negative mother with an Rh positive fetus. So, her first pregnancy will be fine. However, in subsequent pregnancies, that you have that anti DIgG that was formed due to the mother being exposed to fetal blood during the first pregnancy, and in her subsequent pregnancies, this can cross the placenta and, again, lead to the hemolytic disease of the newborn. So the way that you prevent this is through administration of anti-D IgG to the Rh pregnant female during the third trimester and during the early postpartum period. That's if the fetus tests positive for Rh. And then don't worry about this one, you'll talk about that next year. Okay, so yeah, she definitely hinted that it was very important to know your live attenuated vaccines and when you would want to avoid giving them. So make sure you know that those would include MMR, LAIV stands for live attenuated influenza vaccine, and then varicella and zoster. Those are all your live vaccines. And then, important to know is that your live vaccines are going to be neutralized by passive immunization. So, by things like RhoGAM, HVIG, TIG, RIG, and maternal antibodies in the infant. So, you want to give these either together or after a 28-day interval. And then again, we talked about the fact that they're contraindicated in the immunocompromised or pregnant patients. So pregnancy is an immunocompromised state. Okay, so tetanus immune globulin. This definitely has the potential to be a tricky question on the exam, but as long as you know this chart, it definitely shouldn't be a problem. So the only time that you are going to give tetanus immune globulin is if you have a major or a contaminated wound and the patient either has had less than 3 tetanus shots or they have an unknown vaccine status. So in this case, in this scenario, you're going to give tetanus plus tetanus immune globulin. So if you notice the other scenarios, if you have a clean and minor wound with greater than 3 previous tetanus immunizations, but it's also been greater than 10 years since the last tetanus immunization, then you're going to give TD. However, if they've had more than 3 tetanus immunizations and it hasn't been greater than 10 years, then you don't need to do anything. Or if they have a clean minor wound and it's been, they've had less than 3 tetanus immunizations, then you're going to give TD. Or if you have a major or contaminated wound and then greater than 3 previous tetanus immunization and it hasn't been more than 5 years since our last one, then you don't need to do anything. But I would make sure you know this scenario. I think the one she tested on last year was this scenario where you have a contaminated wound and then they have an unknown vaccine status or less than 3 tetanus immunizations, and you're going to give the TIG plus the TD or the Tdap if they haven't had it as an adult. So I think it's if the patient is 19 or older, they do need to have Tdap at least one time as an adult. Okay, so I pulled this chart out of Allie's study guide. It's really great. However, there's only a few Weebots here that you need to focus on. So the first one, the tetanus immune globulin. So the only scenario where you're going to give this is if the patient has a major contaminated wound and a history of less than 3 tetanus shots or an unknown vaccine history. And you're going to give this with Tdap if they haven't had it as an adult, or just TD. Let's see. Then know that your live attenuated vaccines are going to be contraindicated in pregnancy or immunocompromised states. Really important one to know would be MMR. And then the final one that she could trip you up on is going to be rabies and when to give rabies immune globulin. So the only scenario that you're going to give rabies immune globulin is going to be in a previously unvaccinated patient, and that's to neutralize the virus until the patient responds to the vaccine. So if a patient is bit and they have not been vaccinated in the past, you're going to give the rabies immune globulin plus rabies, and that's on days 0, 3, 7, and 14. So on day 0, they'll be receiving their first rabies vaccine plus the rabies immune globulin, and then on days 3, 7, and 14, they're going to receive just the rabies. The only situation that this would be different would be in a previously vaccinated patient. The only thing that you'll need to do is give them the rabies vaccination on days 0 and 3. So if they've already been vaccinated, they do not need the rabies immune globulin because the only purpose of RIG is to neutralize the virus until the patient responds to the vaccination. And I have a couple practice questions that will hopefully make that clear. And here's the first one. So you have a 23-year-old male who presents to the ED with a raccoon bite after volunteering at a local animal rescue shelter. Excuse my typos. Okay, and the patient was previously unvaccinated. So the correct answer here is going to be to give the rabies immune globulin near the wound on day 0 and the serial doses of rabies vaccine on days 0, 3, 7, and 14 at a distant site. So this is in an unvaccinated patient. So exactly the same scenario here. However, we find out the patient has previously been vaccinated for rabies. Like say he's been volunteering at this local animal shelter for a while, and this isn't the first time he's been bit. So in this scenario where he's already been vaccinated, all that you would need to do is give serial doses of the rabies vaccine on days 0 and 3, and he would not require the RIG. So in this question, you have a patient who was riding her bike and she was hit by a car and she presents with road rash. So her vaccine status is unknown. So you're going to want to give her the tetanus immune globulin plus the Tdap. She needs to receive the Tdap at least once as an adult, and since her vaccine status seems, very much unknown, it'd be okay to give her that. So, you're giving the tetanus immune globulin with a major contaminated wound. So think of any scenario, like for example, a nail, like a puncture wound. That nail is most likely dirty, maybe rusty. So that's definitely a scenario for contamination. Or like a road rash, you know, they've peeled off that top layer of skin. Now, you've got dirt and gravel, mixed into the wound. That's a contaminated scenario. So make sure you know that, major contaminated wounds where there's been less than 3 previous tetanus vaccinations or their vaccination status is unknown. You're going to go ahead and give the tetanus immune globulin and the TD or Tdap. So just pointing that out again. All right, that's all I've got for you guys. So if you have any questions or if you happen to notice any mistakes in my slides, I definitely try not to make any, but I make them very quickly. And I'm still a student, I'm still a human. So, please let me know if you find anything. Or if you have any questions or you just want to chat, feel free to shoot me an email or send me a message on Facebook, or I'm happy to give you my phone number if you want to text. I'm here for you guys. So good luck studying, and I'm having my next session at 3 o'clock on Friday, and I will finish up those last 2 lectures then. I'll talk to you guys later.